We're going to move on to our next session. This session will explore how obesity care must be redefined in 2022 and where obesity prevention, treatment, and rehabilitation trends are headed. Please join me in welcoming Dr. Mary Forhan, Scientific Director-elect at Obesity Canada, Dr. Ian Patton, Director of Advocacy and Public Engagement at Obesity Canada. Sorry about that. And Dr. Jimena Ramos-Salas, Director of Research and Policy Consultant at Obesity Canada. Please join me in welcoming them for their session, Trends to Watch in Health and Obesity for 2022. And this session has been made possible by Desjardins Insurance. Welcome all.
Thank you, Francesca, for introducing our presentation. It's my absolute pleasure to be here today. I'm Dr. Mary Forhan. I am the Scientific Director of Obesity Canada. I'm also an occupational therapist by training, so I've been hearing some of the presentations, and it's just music to my ears what I'm hearing about in terms of chronic disease at work. I'm joined today by Dr. Ian Patton, who is Obesity Canada's Director of Advocacy and Public Engagement, and Dr. Jimena Ramos-Salas, who is our Research and Policy Consultant with Obesity Canada. They have been long colleagues of mine, and this is just a delight today. Before we do start our formal presentation, we're really excited to share a short video that will frame some of our key messages today. So I believe that video will be getting queued up, and we'll take a minute to watch this. Okay, thank you. They were just so proud. It's a short, impactful video. It's available online if you feel you want to ever see that one again and share it widely. This video was made by the Obesity Canada team, and it's part of our national efforts to increase awareness and recognition of obesity as a chronic disease. So I'd like to start by highlighting some statistics regarding the prevalence of obesity. As you heard in the video, obesity is a highly prevalent chronic disease in Canada. It's also very highly stigmatized. Traditionally, in population-level studies, obesity has been measured using the body mass index. BMI is used as an indirect measure or a proxy measure, if you will, for body fat. Although we will discuss the many limitations of using BMI as a measure for obesity, it is a population-level studies that allows us to track the prevalence of elevated or changing BMI across populations. Based on BMI measurements, there could be 8.4 million Canadians of adults living with obesity. And we want to stress that BMI is not a diagnosis for obesity, and you'll be hearing a little bit more about that later. So in Canada, BMI has been increasing rapidly, particularly in the higher BMI ranges, such as a BMI of over 40. This is classified as severe obesity. Since 1985, severe obesity has increased by 455% in Canada. And in 2016, it was estimated that 1.9 million Canadian adults had a BMI of over 40. Similarly, BMI has been increasing in children and adolescents. Between 25 to 30% of children and youth have a BMI that would classify them as having overweight or obesity. And 3% of them have a BMI that would classify them as having severe obesity. Unfortunately, since obesity is not treated as a chronic disease in any provincial, territorial, or federal health systems, we do not have accurate surveillance of the level of diagnosed obesity. Instead, all the obesity prevalence data that we have is based on BMI measurements. This is an important point, and as I said, we'll discuss this later in the presentation. The lack of recognition of obesity as a chronic disease also limits the access to treatment for people living with this disease. This creates significant health inequities. So it was in recognition of these significant health inequities affecting people living with obesity that Obesity Canada was established. Obesity Canada is a national registered charity representing healthcare professionals, researchers, trainees, and students working in the field of obesity, as well as individuals living with obesity. Obesity Canada's vision is a day when people living with obesity are understood, respected, and being able and having opportunities to live their best healthy lives. Our mission is to improve the lives of Canadians through obesity research, through education, and through advocacy. We have 3 strategic goals to help us achieve our mission. The first goal is to address the social stigma associated with obesity. You will learn more about this from Jimena later in the presentation. Our second strategic goal is to change the way policymakers and healthcare professionals approach obesity to ultimately improve access to evidence-based prevention and management of resources. So to map health inequities for people living with obesity in Canada, Obesity Canada has conducted several research studies. Since 2017, we have released 2 report cards measuring access to evidence-based treatments of Canadians living with obesity. Although over the last few years, tremendous progress has been made in developing obesity treatments, which can help people living with obesity achieve health and well-being, treatments are not all accessible to Canadians and not accessible to all Canadians as well. So as you will hear from Ian, people living with obesity face constant struggle to find adequate resources and to achieve better health and well-being. Significant differences exist across provinces and territories. This is a classic case, as with some other chronic diseases, about it's where you live in terms of what access to what care you may have. I will not outline the results of our report cards in detail. They are available on our website should you wish to read them in detail, but I'll give you a sense of the level of inequities facing Canadians and with obesity. I can highlight, for example, that less than 20% of the Canadian population with private drug benefit plans have access to the 3 medications indicated and approved by Health Canada for obesity treatment. Wait times between physician referral and consultation for bariatric surgery range from 18 to 106 months. This is across provinces and territories and continues to hinder its utility as an effective obesity treatment. The report card also highlights that no province or territory officially recognizes obesity as a chronic disease. This is despite the recognition that obesity is a chronic disease by the Canadian and American medical associations, the World Health Organizations, and I'll also add that many professional associations, including the Canadian Association of Occupational Therapists, have position statements positioning obesity as a chronic disease. From the perspective of employers, the report card found that 63% of employers believe that people living with obesity could manage their weight if they just set their minds to it. Many employers do not understand that obesity is a chronic disease, and therefore they may not perceive that people living with obesity should have access to evidence-based treatments and obesity management resources. The latest research update that we would like to discuss today is the publication of the new Canadian Clinical Practice Guideline for the obesity management in adults. This is actually a sort of real proud moment for Obesity Canada when we were able to publish these late in 2020. And as you may know, clinical practice guidelines summarize the current scientific and expert knowledge and provide practical recommendations for daily healthcare practice. The vision of the guideline executive committee, which included members from Obesity Canada and the Canadian Association of Bariatric Physicians and Surgeons, was developed a non-biased, scientifically valid, trustworthy, and person-centered set of clinical practice guidelines with specific recommendations that can be optimized for obesity care. These guidelines were also very well informed. For almost every chapter included an author that was a person living with obesity. With this vision in place, we started this 3-year-long process of creating new guidelines in collaboration with researchers, clinicians, and, as I said, people living with obesity. It's important to understand that the recommendations in these new clinical practice guidelines were developed systematically using transparent procedure that included objective evaluation and an evaluation of the quality of the evidence that went into these recommendations. The guidelines include 19 chapters and 80 recommendations and key messages specific for the management of obesity in adults. It has made a fundamental change in the way that we define obesity. The executive created a new definition of obesity to be able to distinguish body size and the disease of obesity. The two are not always the same. The objective was to make it very clear that not all individuals who have an elevated BMI have the disease of obesity, and that it is not used to diagnose a person with obesity. The guideline is framed using a chronic disease management model, and it summarizes all of the best evidence. Based on the evidence we have available today, many individuals living with obesity in Canada do not receive adequate access to evidence-based obesity treatment, and they continue to receive advice to lose weight by going on diets or exercising more. Our research indicates that diets and exercise programs alone are not enough to treat the disease of obesity. Like many other chronic diseases and management programs for such diseases, for example, heart disease or diabetes, nutrition and physical activity interventions should be part of obesity management, not exclusively the obesity management. However, like other chronic disease management strategies, nutrition and physical activity interventions should be provided in combination with adjunctive obesity-specific treatments that can be tailored to meet the individual's health or weight/adiposity-related outcomes. The guidelines recommend that people living with obesity should have access to medical nutrition therapy and physical activity interventions in combination with 3 adjunctive obesity treatments. The 3 evidence-based treatments for obesity include psychological and behavioral interventions, pharmacotherapy, and bariatric surgery. These treatments should be tailored to patients' needs and preferences and be available on an ongoing basis. I've heard the phrase meeting the patient where they're at. This would also apply to obesity management strategies and options. Okay, so obesity is a chronic disease. Patients will need lifelong chronic disease management. So during the chronic disease management process, a patient may need one or more of these interventions that I've talked about, depending on their health status, their preferences, and needs. Unfortunately, based on existing evidence that Obesity Canada has found, we know that most Canadians living with obesity do not have access to evidence-based treatments and struggle on their own to manage their disease. I'm going to now let Dr. Ian Patton share his experience as a person living with obesity. He's also an academic, so he'll bring that lens to his presentation as well. Ian is working with patients living with obesity across Canada to empower and mobilize them to advocate for themselves and to find evidence-based support for their disease. Ian, I'll pass the floor to you.
Perfect. Thank you for that, Mary. Just make sure that get to the slide. There we go. So thanks for that. And yeah, my role today is to kind of bring the lived experience lens to this presentation a little bit. So I'm going to speak a little bit about my experience, but I also have a community of people across Canada that I work with that we use to help educate and inform and empower individuals living with obesity. That's this OC Connect community that we have here on the screen. For us as an organization, it also helps us to engage more lived experiences and the voices of people living with obesity in the work that we're doing. So it helps us be a little bit more patient-centered. As Mary mentioned, I have a background in academia, so I have a kinesiology background, and I did my graduate research in physical activity and obesity. But I've also someone who's lived my entire life with obesity, and it's something that I've become a bit of a patient advocate with. I'm going to skip over a good chunk of my own story because I do want to talk a little bit about what other people experience as well. But for me personally, by the time I was 30, I was about 360 pounds. I had severe hypertension and sleep apnea. And I was really sick, and I had developed this disease even though as a child I was excessively active as an athlete. So I was very, very active, but I still developed this disease. And by the time I was 30, I got to the point where I was really not feeling well. I didn't have a whole lot of energy or motivation. Just getting through the day was difficult. I was living with a lot of pain, and I had some pretty significant health issues. And I realized really quickly that, as someone who had a PhD in this topic, I taught nutrition at a college. I was a certified exercise physiologist. I tried every diet, fad, or supplement you can think of. This was still something that I couldn't manage on my own, and I needed support. So in 2014, I ended up having gastric bypass as part of my obesity management. And I've followed that up since then with other tools like cognitive behavioral therapy and pharmacotherapy and other things like that. And I can say that having access to evidence-based treatments that I've had access to has allowed me to be healthier, happier, and more productive. I'm a better father, better husband, I'm better at my job, and all the benefits have been really overwhelming for my physical health, mental health, and social health. But my experience is not going to be the same thing for everyone else. It's not a one-size-fits-all thing. So I've asked our community to explain in one word what living with obesity meant to them. And what you're seeing on the screen is the results of that. The larger, more bolded words are the ones that are more common. So you're seeing things like lonely and shameful, exhausting, and debilitating. And when you think about it, these are no way for anyone to really experience life. It's a little bit sad, and I'd like to make it so that we could do something better about that. But this is a product of the oversimplification of obesity. We're all told that all we need to do is eat less and move more, yet that's been proven to be wrong. We know that that's not right. And this narrative makes the bias and stigma a lot worse, which makes it harder for us to actually make the changes, and it also makes it harder for us to ask for help. So these feelings of hopelessness and frustration are often tied to the fact that there are things that we can do, but we can't access them. So we don't have enough health professionals who have training in obesity management. Wait times for specialized obesity care are dangerously long. And we don't have access to the medications or therapies that are effective. I can't imagine going to the doctor and being diagnosed with something like diabetes, and my doctor sending me home with a bunch of information about things that I can do to manage this disease, a referral to a specialist program, and then a prescription for medication that he's telling me that I need to take every day to manage this disease. And then only to go find out that I don't have access to those things when I go and try and access them. And that's an everyday occurrence for people living with obesity. And it's something that I think we need to do a little bit better with. So if people aren't speaking up and asking the questions, it's not likely that we're going to see a lot of change. So we do a lot of work to try and empower individuals and provide them with the information that they need to advocate for themselves. And so these are a couple of the tools that we have for people to support their self-advocacy, and so that people living with obesity can bring up these conversations about obesity management with their health providers, their employers, their family, and friends. And these tools are also supported by a vast library of publicly available education. So we do a monthly free webinar series, Connected Conversations. We have a annual conference that takes place in the fall. And we also have a number of presentations and videos that are available online that explain obesity science and also work to reduce weight bias and stigma that we face in our daily lives. And so to kind of get onto that weight bias piece, I'm going to pass it off to Jimena.
Thank you, Ian. That was great. So as Ian mentioned, people living with obesity face pervasive weight bias and stigma throughout their lives and in many different settings, including the healthcare system, in schools and workplaces. Unfortunately, many of us are not aware that we have weight bias beliefs and attitudes about our own weight or about people who have a higher weight. These implicit weight bias attitudes are beliefs that can tend to be very negative and are driven by misinformation and stereotypes about weight and about people living with obesity. This is what we refer to weight stigma. Oh, I think I went back too much. I think I went back. There we go. So the fundamental driver of weight bias and stigma is that many people believe that weight is controllable, or that people have control of their own weight through their individual behaviors or choices, such as healthy eating and exercise. This belief is not based on science, and as you can read in the new clinical practice guidelines, weight is highly controlled by our bodies. Research actually indicates that weight control happens in the brain and that our brain will defend against weight loss. Every time a person loses weight, either on purpose or because of an illness, for example, the brain releases a cascade of hormones to try to prevent weight loss. These hormones can increase our appetite, decrease our sense of satiety, and increase body fat storage. So unlike the popular belief that individuals can control their own weight through individual behaviors, the science of obesity shows that we have indeed very little control of our own weight. Weight, like our height, is also highly genetic. Up to 50 to 60% of our weight is determined by our genes. But because of this deeply misinformed belief about weight control, people living with obesity face judgment. And this judgment can also lead to discrimination, which is when we treat people differently or unfairly. And there is extensive research demonstrating that weight bias can affect our personal behavior and our professional practices with people who have higher weights. For example, teachers who have weight bias tend to believe that students with higher weights are lazy, unintelligent, and unmotivated to learn. And they may unintentionally provide fewer learning opportunities for children, which impacts their educational outcomes. Research also shows that healthcare professionals who have weight bias beliefs and attitudes will tend to spend less time with patients who have a higher weight and will provide fewer interventions for people with obesity because they believe that patients will not comply with their recommendations. This can have serious consequences for the health of individuals living with obesity because it can affect their access to timely and necessary interventions. Research also indicates that weight bias is prevalent in the workplace. As you can see from this report from the UK, many employers believe that obesity is controllable through individual behaviors such as healthy eating and physical activity. The implications of weight bias in the workplace can be many. We have research showing that people with higher weights or who are living with obesity face barriers in hiring and promotional practices. Some research also indicates that people with higher weights have lower salaries. But as I mentioned, this weight bias can be implicit, meaning that we are often not aware of our own attitudes and beliefs about weight and about people living with obesity. And this is because weight bias is very pervasive in our society, and it is often unquestioned. But more recently, there has been a global recognition that weight bias and stigma are driving health and social inequalities at the population level, and that we need action to eliminate weight bias and stigma. So what can we do to eliminate weight bias and stigma? Well, the first step is to do an assessment of our own beliefs and attitudes about weight. And there are many tools in the research community that we can use, but there's no need to make it very complicated. We can just ask ourselves some simple questions such as, do I believe that weight is controllable through healthy eating and exercise? And if the answer is yes, then we can educate ourselves about weight and obesity. And one place to do that, as Ian mentioned, is the Obesity Canada website, and including the new clinical practice guidelines. Another question that we could ask ourselves is, do I make assumptions about a person's character or their intelligence or their discipline based on their weight? If the answer is yes, then the question becomes whether these assumptions are impacting the way that we treat individuals in the workplace who have a higher weight or who live with obesity. And if we are treating them differently, are we actually treating them unfairly? So it's important to be aware that individuals who have faced weight bias can internalize these negative attitudes and beliefs and even apply them to themselves. Internalized weight bias can have many negative effects on a person's health. Research indicates that internalized weight bias can be a barrier for obesity management even, as it can affect people's behaviors. For instance, many individuals with obesity will avoid health-promoting behaviors, such as going to see a doctor, for fear of being blamed and shamed for their weight. We also have research that is very clear. Shaming someone for their weight is very harmful. And unlike what many people may believe, it does not help people to lose weight. Feeling shame of our own bodies is never helpful. So once we become aware of our own weight bias attitudes and beliefs, and we consider how these attitudes and beliefs impact our behavior or our professional practices, we can start to change those practices. For example, we can review our workplace policies or benefit plan policies to see whether they are leading to more unfair treatment for people living in higher weights or with obesity. For example, in benefit plan providers, they could seek information about obesity and ensure that their policies are based on the latest scientific understanding of obesity. Many benefit plans currently put obesity under the lifestyle box rather than the chronic disease box, for example. And another thing that employers and benefit plans providers can do is to reach out to Obesity Canada, for example, and explore how their programs and policies can be aligned with the new clinical practice guidelines. For instance, many benefit plans do not cover obesity treatment, as Ian mentioned, in the same way that they cover treatments for other chronic diseases. So there is an opportunity here to align benefit plans programs with the evidence-based treatments outlined in the clinical practice guidelines, as well as to align other policies in the workplace to ensure that they're not unintentionally contributing to more weight bias and stigma. So ultimately, for us to prevent further health and social inequalities in Canada, we need to ensure that all employees living with chronic diseases have access to evidence-based treatments. If we have learned anything during the COVID pandemic, it is that the most vulnerable groups of our society have tended to pay the higher consequences. And people living with obesity should have access to evidence-based treatments and supports, just like any other person living with a chronic disease, such as diabetes or cancer or hypertension. And what we're saying here is not that individuals living with obesity need something more or something extra. We're just talking about leveling the field and making sure that people living with obesity actually do have access to the same standard of care that other chronic disease models offer. And for example, like Mary mentioned, we need to make sure that people living with obesity have access to medical nutrition therapy, physical activity, pharmacotherapy, behavioral therapy, cognitive behavioral therapy, psychological interventions, and surgery, for example. And of course, like any other chronic disease care model, obesity care models should also validate people's experiences and move beyond simplistic approaches, such as telling people to eat healthy and exercise more. As we heard today, obesity is a very complex chronic disease, and weight is not solely controllable through individual behaviors. We must change this fundamental misconception and build policies based on science and patient experiences. And with that, I'm going to pass it over back to Mary to take us to the finish line.
Excellent. So what we have here is just some resources. I'm going to go back to the slide here. So if anything has grabbed your interest and you'd like to learn more, there's some resources here from Obesity Canada. And then finally, I would like very much to just thank our partner, Desjardins Insurance, and the conference organizers for inviting us. So Francesca, I know we don't have much time, but I think there's a little bit of time left for some questions.
Thank you all. That was really great. And it's so insightful to understand weight bias. And maybe because this is a benefits conference, can you just speak to, Jimena, you talked near the end about benefit plan design and lifestyle versus chronic disease. Would you say that there are many benefit plans today are not modern, or they're not modernized with their contract language?
Certainly, that's our experience based on our report card evidence that when we talk to insurance companies, we surveyed insurance companies and benefit plan providers, and very few of them actually include obesity as a chronic disease and actually put obesity in the lifestyle and behavioral style programs instead. So that limits, of course, the types of treatments that they can cover for people living with obesity.
Great.
So we definitely need to modernize.
Yes.
I like that question.
Work to be done. And just to leave us with one final thought, and I'll let one of you answer in the interest of time. If you could just leave us with one piece of advice of, employers that want to remove the weight bias in their workforce, what are things that employers maybe should avoid when they're trying to support their employees living with obesity?
I'll go first, and then I'll see if anyone has.
We have no more time for that, so Mary, it's you.
So please avoid the weight loss challenges in the workplace. They're not effective, and they create more harm than anyone is aware of. So please stop doing that.
That is very insightful advice. Thank you, Mary, Ian, Jimena. Thank you so much for your time and your presentation.